screen. I will just say, for those of you who attended the AOFAS meeting, you hopefully saw Dr. Frank's presentation. I thought it was outstanding, and I'm hoping that we get at least some of that here. Dr. Frank is very knowledgeable about biologics, regulatory standpoint, and has a very a strong grasp of what's effective and what's not effective and kind of where the space is going. So I'm excited to see this talk again. And Rachel, thank you for being here and being our multidisciplinary speaker today. Take it away.
All right. Well, Ken, thanks very much. It's an honor to be part of the foot and ankle team today, and appreciate the opportunity to speak. For those who were at the AOFAS, this might be a little redundant, but they say things are better remembered when you hear them multiple times. So hopefully, if you did hear this, this will just reinforce the points. As always, I'm, an open book. So any questions, I guess, feel free to put them in the chat, or we could chat after. And any other questions, feel free to email, call, or text anytime. And we'll get started. And we'll leave a little bit of time for questions at the end. So you guys can see my screen okay? Perfect. I do have some disclosures. None are directly relevant to the content of this talk, but they are available online through the AAOS. As we all know, biologics are the hottest topic in orthopedics in general, and I would argue that currently they're the hottest topic in medicine. The field of biologics is very vague and very broad, and it encompasses a lot of different tools and modalities that we have, and from vaccine development all the way to treating osteoarthritis, the biologics are really coming into play. And when you look at the media is showing, in fact, here locally in Colorado with this first advertisement, as well as nationally and internationally around the country, that biologics, PRP, stem cells, so to speak, can cure everything, ranging from arthritis to Achilles pain, to wrinkles, to baldness, and can even take this degenerative subluxated osteoarthritic bone-on-bone hip, and for a few simple treatments, turn it into a normal hip. And that's what our patients are seeing. That's what they're hearing. And that's what they're coming and asking us for. One of the real problems, and I always like to put this slide in when I give a biologics talk, is that they're not safe if used irresponsibly. And as one of my mentors would say, there's no free lunch. So problems can occur with the irresponsible use of biologics. And unfortunately, we see more irresponsible use than responsible use when patients are referred into us after a failed biologic treatment, including things like infections or even death or tumor formation. And so we have to be careful when we apply biologics to patients. When patients come in asking for biologics, we have to set the stage, and we set the stage by understanding what they want to know. And what they want to know is the following. They'll ask it in a variety of different ways, but it really boils down into these 4 questions. 1, how long does it last? So if you do a PRP, Dr. Hunt, how long does it last? That's what they want to know. Can they get back to running? If they do the injection today, can they run in their marathon next week? If they do nothing, is that okay? Is it okay to live with their osteochondral lesion? Is it okay to live with a meniscus tear in the knee, for example? They want to know if it's okay to live with their current symptoms. And our job, our task is to manage expectations. And nowhere is this more important than with biologics. We have to think about expectations versus reality. So this is my pup Murphy. And when we have a barbecue, his expectation is that he's going to get all that delicious looking meat, when in reality, he's going to get this carrot because it's a better choice for him. Patients are the same way. If they come in and they're running a 550 mile, but their goal is a 530 mile, and they want PRP to get them there, you have to be realistic that your shot may not give them, and in this case, I would argue will not give them those extra 20 seconds per mile. So you have to be careful with what they want. And oftentimes, once you explain what the biologics can, and more importantly, cannot do, they sometimes don't want the biologic treatment anymore, but they're thankful for the education. When we think about a variety of different pathologies, whether it be arthritis, cartilage defect, Achilles tendinopathy, et cetera, we can think of a lot of different types of non-operative treatments, including those that you see here, depending on the pathology that we have. But really, biologics has grown into one of our most commonly applied non-surgical, minimally invasive treatment modality. And why is that? Well, let's talk about it a little bit. Before we talk about what we can use, we should talk about how and why we can use them and what the rules are. And this is no more important, or it's equally as important, I should say, now as it was 2 years ago, 5 years ago, 10 years ago, but it's coming more into play now due to some recent FDA updates. So I'm going to go through those a little bit. So first and foremost, what are the regulations? Can anyone put anything into anyone? The answer is no. So there are regulations regarding the use of biologics in medicine. And this comes down to the HCT/P regulation oversight, or the human cells, tissues, and cellular and tissue-based products, HCT/P oversight. And there's two different centers, as you see below, in the government here in the United States that control the HCT/P pathway. And this paper published in JKS gives a great overview, at least in 2017 or so, of what those regulations were at that time. And they really haven't changed from then to now. Stem cells, so to speak, anything called a stem cell is regulated as a biologic and device, which means it has certain rules before it can be put to market and applied clinically. Now we know, and we look at this chart, it makes sense that as the therapeutic class goes up, the regulatory burden goes up. So more simple classes or devices of drugs or biologics will have less regulatory burden. And as we get to formal biologics or stem cells, so to speak, there's a much more stringent regulatory burden. There's two categories of increasing risk according to the HCT/P pathway, and these are 361 and 351, and they don't go in order, which is confusing. But the goal is to assure that the safety, integrity, function, and efficacy of the products are maintained after processing. The whole goal of 351 and 361 is not to make us as clinicians or us as researchers have torture when it comes to getting new products to market. It's to keep our patients safe. But there are some nuances, particularly when it comes to one of these pathways, that makes getting a product to market almost impossible. So let's talk about 361 first. So this is from the FDA. 361 is the easier pathway. This is considered biologics that are in a lower risk pathway. The FDA registration occurs as a manufacturer, but no clinical study is required. What does that mean? That means if the product is classified as HCT/P 361, you can put it to market right away. You can put it in use right away. This, interestingly, includes all allograft tissues. So when we think about PRP and potentially adipose or even bone marrow being regulated under 351, which I'll talk about in a second, it's amazing that we can put allografts coming from a donor versus an autologous source of your own tissues in a 361. But essentially, this is why we can get new allograft products to market much quicker, as opposed to even some of our autologous tissue. Now, 361 means you can't just be a 361, you have to have some criteria. And this is what it boils down to. And I know this is a busy slide, but I'll summarize it. It means that the product is minimally manipulated and for homologous use. Now, there is some wiggle room with what minimally manipulated means. And certainly homologous has some wiggle room too, because is amnion really homologous in male patients? But it's hard to say, right? Males don't really carry or don't carry amnion. And but if you consider homologous a mesenchymal cellular line, then maybe they do carry amnion. So it's really up to the interpreter, but the FDA is the ultimate guideline for all of these. And so as you can see, there is some wiggle room. If it doesn't meet this criteria, meaning if it's not minimally manipulated, not for homologous use, et cetera, then the biologic is classified as a 351. And when in doubt, classified as a 351. So what's a 351? This is a little bit confusing because you guys have probably heard these abbreviations before: IND, IDE, BLA, PMA. This is what this means. So you take the therapeutic class of the agent, whether it's a drug, device, or biologic, and you essentially have to go through a clinical trial application as well as a marketing application. And depending on the therapeutic class of the agent, that dictates which type of application you're going to have to do, whether it's an IND, meaning an investigational new drug application, or an NDA, a new drug application, or a BLA, which is a biologics licensing application, et cetera. So there's a lot of nuances, but these are the terminologies that we need to be familiar with. 351 products are the ones that require years and years of clinical trials before that product can come to market. They require pre and post-market studies, including preclinical lab and animal studies for safety. They require an IND, investigational new drug application, and that must be performed prior to initiating clinical studies. And then we all know about phase 1, phase 2, and phase 3 clinical trials. They have to undergo all 3 phases with very few exceptions. And then they have to be submitted as a safety and efficacy application as part of their biologic licensing agreement. And so there's a lot of things that have to happen for a drug to go through, or for a device to go through, or for a biologic to go through a 351. And this costs not just hundreds or thousands or even hundreds of thousands of dollars, but this can cost millions of dollars. And so this is why manufacturers, industry companies, researchers, et cetera, want to get everything as much as possible into 361, because 361 does not require this much research, this much of a stringent protocol to come to market. Now, what does this mean to us as orthopods and as sports medicine clinicians, as foot and ankle clinicians, et cetera? Well, when we think about what we can and cannot use in patients, we have to think about, again, 351 and 361 and what's truly allowed with the given agent that we're using. So in November 2017, the FDA put out a memo. They stated, quote, "Over the next 36 months, we intend to exercise enforcement for IND BLA and PMA for certain HCT/Ps." Now, they said we intend to force. It was not a legal statement. They were recommendations by the FDA. But what they also stated was, we're going to give you 36 months to kind of get your act together. So for all the stem cell minute clinics out there, for all of the places advertising, I'm sure you see these every day on your cookies and on your social media and on your LinkedIn and whatever, where you see advertisements for regen this and regrow that. The FDA was saying to those places in particular, starting in 2017, we're going to start enforcing that your products have to go through proper 361 or 351. But if they don't, we're going to come after you, but we're going to give you 36 months, 3 years. Fast forward to 2020, when this should have been enforced, and we're in the middle of a worldwide pandemic. So that got delayed even further until June of 2021. So just a couple months ago, when the FDA put out a memo on June 3rd, 2021, talking about important patient and consumer information on regenerative medicine therapies. And all they did was reaffirm the 2017 memo. Nothing new, nothing different. But I got to tell you, I got about 100 emails that week. Everyone freaked out about how the regulations were about to change. Nothing was changing. Nothing has changed. It's just now that the pandemic is somewhat under control, the FDA is going back to their 2017 memo. The 36-month grace period's off, and they're saying we're going to start enforcing these. So I would urge anyone in the practice, anyone in the office, anyone in the audience who has, for example, a website that advertises stem cells or advertises things that may not be appropriate by the FDA, to check your website and make sure the language is correct. When this came out, I actually had my website scoured and looked for words that would be misleading, and I had to remove quite a few things. And it's unfortunate because from a marketing perspective, those are the buzzwords that get patients in. But from a legal and ethical perspective, it's the right thing to do. So got to be careful with advertising the use of the word stem cell for treatments for patients. What does this actually mean for us? Here's the take-home slide for this portion of the talk. We've got to be transparent and upfront with our patients, and we've got to disclose financial relationships. If you have a relationship with a PRP company or a biologic company, and you're using that PRP product or that biologic product, you need to let your patient know. That's like anything in life that we do from an orthopedic perspective, but it's critical with biologics where there's so little data at the end of the day proving their efficacy. We've got to be careful with marketing, and we've got to understand patient and product safety and efficacy and recognize what's on label versus off label. What about things like adipose, amnion, et cetera? Because this is the real sticking point. Are these 351 or 361? Because if they're 361, we likely can use them, but we don't know. That's the big question. No one's come out and said adipose is this, or amnion is that, or PRP is this, and stem cells are that. And so it's often left up to interpretation. And the big question is, who's going to be doing the interpreting? Is it you? Is it an FDA official? Is it the patient, et cetera? So the jury's still out on what is exactly allowed in terms of FDA 351 versus 361 here in 2021. In summary, if you wanted to take home anything, I would say, if you're going to use a product, it should be under 361 HCT/P pathway, which means minimally manipulated and for homologous use. And you can't do any of these things unless you're involved in an IDE clinical trial for a 351 product, including culturing cells, taking them out of the OR and clinic, sorting cells, adding growth factors, adding enzymes, et cetera. This cannot be done unless you're involved in an FDA-approved clinical trial. And so if you hear of people doing this, or if you yourself are doing this, you shouldn't. And this is only in the United States. So around the country, around the world, this may be different. And when you read papers from around the world, read the abstracts critically, but more importantly, read the content of the paper to determine what that country's regulations are. All right, we'll say we've said, okay, great. We know about the regulations. Now we actually want to use these products. How do we use them? Well, why do we use them? And that's what we have to understand. So from 30,000 feet, what happens? We get an injury. Could be a paper cut, could be an ankle sprain, could be an Achilles rupture. At that site of injury, our body brings growth factors, both good and bad, but ideally more good than bad, to the site of injury. And ultimately, we get some sort of repair. Again, if it's a paper cut, we get a clot. If it's an Achilles rupture, you get some sort of fibrous clot and hopefully some collagen healing strand to strand with the right type of therapy and immobilization, et cetera. But you get some sort of healing. And it's the growth factors that are the key. With growth factors in our body, this is not an exhaustive list, but these are some of the important ones. We've got both good growth factors and bad growth factors. And the whole goal of biologic therapies are to intrinsically optimize your good growth factors, the ones already present in your body, not necessarily delivering more, although some biologic therapies can do that, but to take the ones already in your body and optimize them, turn them up, and then hopefully minimize the catabolic growth factors, or the ones that are anti-growth and turnover cells when we don't want those cells turned over. What are our biologic options in 2021? Well, this is a fairly exhaustive list, and we have autologous blood products. Most commonly, we think of PRP. We have cell-based therapies, we have placental tissue-based therapies, and we have isolated growth factors that can be injected. I'm going to talk a little bit about the wide variety of biologics that we have, and then most of these slides will then be applied to applications in the foot and ankle, given that we're in a foot and ankle meeting. But viscosupplementation is a biologic that we can use, and it's used most frequently in the knee joint, although off-label in other articulations. And visco is the hyaluronic acid injections, the rooster shots, the gel-based injections. These have therapeutic properties, including those that you see here: shock absorption primarily, joint lubrication, et cetera. There's a lot of different formulations. At least in the knee world, insurance coverage is changing by the day, and certain insurances, and in particular UC Anthem, does not allow for viscosupplementation, at least in the knee. And these are actually more expensive when paying cash than PRP. So this represents a little bit of a clinical challenge when this might be indicated for a patient but not covered. When we think about HA, we can think about where it comes from. So some products come from naturally derived avian sources, some come from bacterial derived sources, some from chemically derived avian sources. It can be in a hydrogel or a solution or a fluid. It can be cross-linked. It can be concentrated. You can get them in series of 1 to up to 5 injections, depending on the cross-linking and concentration. And then clinical efficacy, at least in the knee, has been reported for up to 6 months following appropriate injection in about 70% of patients with mild to moderate knee osteoarthritis. What about PRP? What is it? Well, let's take a step back. First of all, what's blood? Well, we know blood is composed of red cells, white cells, and plasma. Plasma is the non-cellular portion of blood. It contains the platelets and the growth factors. The growth factors are the key. PRP is defined by the American Red Cross as a sample of blood plasma with greater than 2 times platelet concentrations above baseline levels. Now that can be 2.1 times or 2 million times or 2 billion times. There's no definition other than greater than 2 times the concentration of platelets above baseline blood levels. And therein lies the problem with understanding a lot of the PRP research that's out there. Now, platelets have a normal biologic role for tissue healing. Again, they contain growth factors and proteins. The growth factors are released from alpha granules, and that's really critical. So alpha granules are the structures that you see at the bottom of the page hidden inside the platelet, and those need to be activated. And once those alpha granules are activated, they release a variety of different growth factors, including several that you see here. Now, each of these growth factors has different properties. Some are good for collagen, some are good for tendon, some are good for cartilage, some are good for meniscus, some are good for vessels, et cetera. All these growth factors have different end targets in terms of what they're able to do in the body. The whole goal of PRP is to try to get these growth factors to the site of injury and hopefully let the ones that need to work. So an example, when we talk about arthritis, when we have a focal chondral defect, like you see here on the bottom left, and we want to treat with PRP, what we hope is that once the PRP is injected into this area, the alpha granules will degranulate once those platelets are activated. The activation typically occurs via thrombin or calcium chloride, which can be put into the end product of PRP. And then once those growth factors are released from the alpha granules, we hope that certain growth factors, such as TGF beta, and PDGF will go and help optimize the biologic environment of that focal chondral defect so that it does not become diffuse arthritis like we see on the bottom right. So we want to prevent that, and we hope that the growth factors from the PRP, from the platelets, will ultimately do that. How is PRP used? For anyone who's not familiar with this, essentially we draw peripheral blood. The volume of blood depends on the system. With one of the most popular systems that we use here at CU, we draw 15 cc's of blood, so not a lot. We place that into the centrifuge machine, we spin it down, and then after we spin it down, we can get the PRP out, and we simply fractionate the PRP, and it basically, the spin uses specific gravity and gets our layer that we want toward the top, and I'm going to show you that in a little bit, and then we can inject that into the site of injury. After the spin, we essentially get 3 layers of stuff, so to speak, and this is based on weight. The red blood cells are the heaviest, they go to the bottom, we don't want those. The plasma goes to the top. We don't typically want that. That's for certain applications, but not for the most common ones. What we're really looking at is the buffy coat, which is right in the middle. That contains platelets and then some white cells, because white cells are heavier than the platelets, but not as heavy as the red cells. And there's different types of end products that you can get depending on the system that you use. You can use a plasma-based system, which has one single spin, which is going to result in less platelets and less red cells because it's going to be more of a merge with that single spin. Or you can get that true buffy coat system that I talked about here, where you get the buffy coat, and that involves a couple different spins, but then you're separating out the layers even more, and then you'll be able to really concentrate your platelets. And with that, you'll also get some more white cells. Now, one key to remember is that white cells can be bad. They can degrade normal matrix. And that with platelets, it's not like more is always better. There is a sweet spot. What that sweet spot is, we don't fully understand just yet for every clinical indication. But we do know from some basic science studies that more is not always better. And so we really need to optimize our end product based on the pathology that we're treating. So this is a nice picture that my buddy Jorge Chala out of Rush put together, and it really shows the spin quite nicely. So you can see after you've spun the PRP down, or the blood draw down to make PRP, you get your red cells at the bottom, your platelet poor plasma at the top, and then you can see that little layer in the middle, a different color there, the buffy coat. And in the buffy coat, we've got the platelets, which ideally contain growth factors. We've got growth factors in and of themselves, and then we've got the white cells. And the different growth factors are really the key. So if we take a bunch of different growth factors and we say, okay, growth factors, we want you to start working, we have to think, how do we get them to start working with the intended target? So for example, if we're trying to optimize a cartilage environment for, say, cartilage repair or restoration, we really don't want VEGF. We want noggin and TGF beta 1, but we don't want VEGF. If we're trying to optimize muscle recovery, then what we want is VEGF and noggin, but we don't want TGF beta 1 from a fibrosis perspective. And so we really try to optimize our growth factor end product by getting rid of TGF beta 1. And then if we're trying to optimize bone healing, so say non-union, malunion, AVN, et cetera, we want to get rid of noggin, but we want to keep VEGF and TGF beta 1 because we want to block BMP. And I'm not going to get into the weeds on all the different cascades for all these growth factors, but this is what we want. And the key to biologics, at least in my humble opinion, is figuring out how to target the growth factors from the biologic to the area of interest by allowing for some sort of scaffold or signaling cascade that can select for the growth factors that we want and eliminate the growth factors that we don't want. We're not quite there yet, but I think that's where a lot of the research is going. When we think about PRP, most of us in the audience have heard the 2 different common types of PRP, including leukocyte-rich versus leukocyte-poor PRP. And this really has to do with the number of white cells that are in the end aliquot of your sample. And one way to understand this is when you're putting in PRP, if you're having a leukocyte poor product, which most of us use for most conditions that are acute and for arthritis, we want a more clear or yellow based product. If you're putting in something that looks viscous or red, you either have a bad spin or you have a leukocyte rich PRP, and that may have the opposite or even a deleterious effect for what you want. Now, leukocyte-rich PRP should have a more red appearance, and this is often used for our chronic tendinopathies and more of our chronic conditions, although there's some discussion on this in terms of what's best. When we have leukocyte-rich PRP, we get a lot of white cells. Your patient's going to feel it when you put it in there because it's going to hurt more so than a leukocyte-poor PRP. Leukocyte-poor PRP is not benign. There are still some white cells in there, but not nearly as many. But again, this is kind of a poor man's way to make sure you're putting in what you think you're putting in. If you look down at the end product and it looks red, it's most likely rich. If it looks yellow or clear, it's most likely poor, and you should make sure you're putting in the right thing. And that paper that I highlighted here by Lisa Fortier and Drew Lansdowne, one of my former co-fellows at UCSF now, is a great summary of the different types of PRP. And it's a 2 to 3 page read, but I would suggest everyone take a look at it if you're interested in getting background info on PRP. And I'd be happy to send you guys that article. So, okay, now we understand PRP. We understand what it is, what it isn't. Okay, what should we use? Because there's a million different types of PRPs on the market. Well, that's a good question. And I apologize, but I don't have an answer for you. And the reason I don't is because when you look at the literature is unfortunately fraught with variability. Comparing one study, even in the same institution, to another study might have 2 different types of PRP systems. And so it can be very difficult to compare apples to apples. We're not even comparing apples to oranges here. We're kind of comparing apples to pizza. And so it's very, very difficult to understand which PRP system you should use for a given clinical application because the literature is not high quality enough to guide us. When we look at PRP and we really try to go to the literature and say, okay, does it work? Well, let me tell you, when you go to PubMed, and this search was done in September, so just a couple of weeks ago, if you search for PRP, you're going to get just over 13,000 hits. Pretty good amount of hits. And when you look at the number of hits in the last 5 years, they have exponentially increased. But what are our patients looking at? Well, they go to Google. And when you go to Google, again, done in September, we have 44 million hits. And I'll tell you, when I performed this same search last year in September 2020, and I bet I have a screenshot to prove this, 22 million hits. So we have doubled our number of hits on Google, which is the most common search engine that our patients go to. And if they're searching PRP and finding 44 million things to read and learn about it, you better believe they're coming in their head more knowledgeable than anyone else. And they're going to ask you, I want this PRP, or what PRP should I have? And this study said this, and this, advertisement said this, and you've got to be able to talk to them intelligently about this. So who's to say does PRP work? Because there's a lot of different studies, both in the academic and in the mainstream literature, supporting and negating its use. When we look at the knee, which is the most common application of PRP and the most common area for research, we can see from these top studies, PRP does not work for knee osteoarthritis, but from these middle studies, it does work for knee osteoarthritis. And from this last study at the bottom, it might work. I'm part of an academy work group right now, and we're looking at 59 different papers on PRP to come up with consensus statements. And I got to tell you, it's unbelievable. And this is just for knee OA. It's unbelievable. There's just no consensus. And so it's very difficult to determine if PRP works, because for every good study that I say, yep, I think that really shows PRP is supportive from a symptom modifying perspective, another paper shows, yeah, that might be true, but it's not a disease modifying agent. And so thus it's not helpful. So it depends on what your outcomes are and what you're measuring to determine what might be beneficial. And that's what my pup Murphy has to respond when we talk about PRP at home. So what about in the foot and ankle? Because that's what we really want to talk about today. Well, does PRP work for Achilles? This is a common question that I get, even though I'm not an ankle doc. Patients come in and they ask, hey, can you put some PRP in my Achilles? My neighbor got it. My best friend got it. I heard this pro athlete got it. Well, when you look at this study, the answer is no. This is published in AJSM out of Denmark. PRP is not helpful for an acute Achilles tendon rupture managed non-operatively. If you look at this study, also no. And if you look at this next study, yes. So a little bit of mixed literature depending on the study that you read and the country that you're in, because we're going from around the world with these studies. When you look at Achilles injuries continued, PRP for a non-operative treatment of acute ruptures, this study says no, published in Arthroscopy. This study out of Belgium also says no, and this was a systematic review with meta-analysis, and this was for chronic mid-substance tendinopathy, so not for rupture, but still the answer is the same. And then finally, another study, double-blind, prospective, randomized trial performed out of Denmark looking at PRP for chronic mid-portion Achilles tendinopathy. The answer is no, there's been no difference. So the summary statement is for Achilles ruptures treated non-operatively and Achilles tendinopathy treated non-operatively. The overwhelming evidence would suggest that PRP is not quite where we want it to be to say that its use is supported by the literature. What about for ankle OA? We would suspect that ankle OA would have better indications just given the literature in the knee. And when you look at this first study, looking at 12 different cases of hindfoot and ankle osteoarthritis, the answer is no. PRP creates, and it's not saying that PRP makes you worse. And I want to be very clear on that. These studies just show it doesn't make any better compared to placebo. But this study would suggest out of FAI International that PRP does help for ankle osteoarthritis. And this other study also suggests that PRP does help for ankle osteoarthritis and even can postpone surgery for ankle osteoarthritis. And so I would argue that PRP does have a supported role for the use of the treatment of ankle joint osteoarthritis. But again, we have to understand, is this symptom modifying or disease modifying? And I would argue based on the bulk of studies, both in the knee and the ankle, it's symptom modifying, but won't change the natural history of progression of osteoarthritis. What about as a surgical adjunct for osteochondral lesions of the talus? Because this, again, this extrapolates to osteochondral lesions of the femur when we're talking about the knee. And there's fairly good literature to support the use of PRP in those scenarios. When we look at the literature, KSSTA, FAI, and AJSM, we can see that in all of these, PRP is supported as a surgical adjunct for the treatment of osteochondral lesions of the talus. And in many of these studies, this is compared to control. And so this may be something that you want to consider augmenting the surgery that you're already doing and adding a biologic to hopefully help that osteochondral lesion of the talus heal better. Why is the PRP literature so confusing? Well, the reason is very simple. It's because we as researchers are not very good at reporting what we do. In fact, when you look at this study now published a few years ago out of JBJS, again, led by my friend Jorge Chala, he looked at 105 different publications on PRP from all over the body and found that just over a tenth, reported on every processing step. That means about 9 out of every 10 authors are choosing for some reason not to report on how they drew the PRP, how they processed the PRP, and how they injected the PRP, or even what type of PRP that it was. So it's hard to take a study that says PRP is the next best thing since sliced bread, but then you go to that study and you want to extrapolate those methods for your patient and not have a protocol to follow. We need standardization and we need consensus so that we can better understand the literature and apply these studies to our individual patients. All right, moving on to stem cells, the holy grail. At least this is what our patients think. They think they'll take their nearly bone on bone, tibio-talar joint, avoid a total ankle, avoid a fusion, put in some stem cells, and they'll be running marathons again. And this is what I'm hoping you'll look at them like, because that's not what happens with stem cells. What are stem cells? Well, when you look at the NIH and you look at the ISCT, which is a governing body on stem cells, they actually can't agree on what stem cells truly are, which is kind of fascinating, as these are our two most official governing bodies when it comes to biologics and stem cells. I will summarize it by saying that stem cells, or MSCs, are found in native tissues, such as your bone marrow or your adipose, but they're found at very low concentrations. And from an orthobiologic perspective, the goal is to intrinsically optimize those cells, increase their concentration, and get them to the site of injury. Common cell-based therapies in orthopedics include bone marrow-derived MSCs or mesenchymal stem cells. And we call them MSCs because they truly are mesenchymal cellular lineage. And that can stand for MSC as mesenchymal signaling cell, medicinal signaling cell, mesenchymal stem cell. I don't like the word stem cell because what we end up putting in is not truly a stem cell, but that's the nomenclature that most of our patients use. And in fact, most of our colleagues use. So we'll stick with MSCs as an easier way to describe what these things are. But they typically come from bone marrow. They can also come from adipose. They can come from synovium, from tendons, from muscle, from ligaments, from the blood. They can come from a variety of different areas. In the shoulder, we're learning that they can come from bursal cells. So very interesting in terms of where stem cells can actually come from. But they most commonly in orthopedics, when we talk about MSCs, we're talking about bone marrow and adipose. So bone marrow-derived MSCs come from bone marrow aspirate, or BMA, which can be aspirated from a variety of different locations, including the iliac crest, the proximal tibia, the distal femur, the proximal humerus, and even the calcaneus. And then these cells can be centrifuged to concentrate the MSCs to what we know as BMAC, or bone marrow aspirate concentrate. Now, BMAC is actually a trade name, but most of us use it. But BMC is also referring to the same thing, or bone marrow concentrate. When we think about where we can harvest it, again, we can harvest from a variety of different places, as I've just mentioned. And how do you pick a harvest site? Well, when you look at the literature from a basic science perspective, the basic science would suggest in all three of these papers that the posterior superior iliac crest is better from a cell yield perspective, but you've got to weigh the pros and cons of patient room and setup. From a clinical perspective, it's never been proven. So it's never been proven in a clinical outcome study that comparing cells from the iliac crest posteriorly to any other site results in better clinical outcomes or patient-reported outcomes. So for me, I weigh the patient setup and room setup with what I'm trying to do. And so if I'm doing a shoulder procedure, for example, it's less ideal to take cells from the posterior crest because I'd have to set them up lateral or prone first and then flip them over to beach chair if I'm doing a cuff, for example. And that is less ideal for myself and for the room setup. And so in those cases, I'll typically take it either from the anterior crest or from the proximal humerus. So again, just depends on the studies that you read and what you feel is best for your patient. When we talk about bone marrow,
could you try again?
Sorry, my Siri is going off. When you talk about bone marrow MSCs in the knee, and again, I'll start with the knee because that's kind of our prototypical joint when it comes to understanding bone marrow and the use of bone marrow in an arthritic joint. When you look at all of these studies, and these studies combine both arthritis and focal chondral defects, we would find that bone marrow concentrate is most beneficial as a surgical adjunct for focal chondral defects, but not as beneficial for osteoarthritis. In fact, PRP is more supported than bone marrow for the treatment of general osteoarthritis. What about in the ankle? Well, when we look at ankle osteochondral lesions and we look at the use of bone marrow as a surgical augmentation for the treatment of ankle OCD lesions, we find that bone marrow concentrate as a surgical augment for ankle OCD lesions is similar to the knee, encouraging relative to the generalized treatment for osteoarthritis. And here are some of those studies for osteoarthritis, encouraging, but not specific for a disease modifying effect. So very similar to the literature in the knee, but potentially a little bit more encouraging, and certainly more work is needed. And hopefully many of you are engaging in this work here. What about for Achilles? Can we treat Achilles ruptures with bone marrow aspirate, or can we augment surgery for Achilles ruptures with bone marrow aspirate? Well, when we look at bone marrow concentrate as a surgical augment for Achilles ruptures, there are good outcomes, but there's no control groups, at least in any of the studies that I saw. And same thing for Achilles tendinopathy, good outcomes, but no control groups. So the big question is, would those good outcomes have been the same if you didn't use the bone marrow? And unfortunately, the authors of these studies did not use control groups. And so we don't know the answer to that. What about fat? There's a saying right now, at least in the knee world, fat's where it's at. Why is that? Well, fat's interesting, or adipose tissue. It's interesting because it's readily available, particularly here in America. And it can also be arthroscopically harvested in the knee joint from the infrapatellar fat pad. And then what happens is it's mechanically processed to wash out the lipids, but you try to retain the SVF, or stromal vascular fraction. And that's rich in MSCs and rich in extracellular matrix. And one of the advantages of the adipose over the bone marrow cells is that there's no significant decline of cell number with age. And furthermore, adipose cells are contained within this structural scaffold, which increases their cell residence time, which may mean that the cells stay at the site we get them to go to longer. The biggest question many of us have is, are these cells good? Because more is not always better. Just because you have more doesn't mean that each cell is efficacious or each cell matters. And so that's the biggest question. And lots of bone marrow advocates say, well, I don't care that you have more cells. Those cells aren't doing anything. And that may be true. More work is needed in this very important area. Well, what do the outcomes show? Well, when we look at adipose-derived MSCs for knee osteoarthritis, again, we've got a lot of different studies. And in fact, adipose-derived MSCs for knee osteoarthritis are favorable, more favorable than the independent studies for bone marrow, but a head-to-head study comparing adipose to bone marrow in the same patient, which would be nearly impossible to be performed, has yet to be done for obvious reasons. And so we don't necessarily have head-to-head comparisons yet. What about in the ankle? Well, there's not as many studies for adipose in the ankle just yet. I think it's just a newer topic. But when we look at adipose-derived MSCs for ankle osteoarthritis and or cartilage repair, we can see again that the studies would show that there are favorable outcomes, but we have to take that with a caveat because we don't always have control groups. And often these are combined with other procedures. In fact, many of these papers, both in the knee and the ankle, combine adipose with PRP or combine adipose with bone marrow. And so it's hard to say if the effect is from one biologic or the other or none of them. When we look at Achilles, there's a couple different studies looking at the use of adipose-derived MSCs for Achilles tendinopathies. And what we can see is that the literature would suggest that adipose is favorable. But again, we need better literature with more comparison groups to understand if this is truly a result of the adipose or more so a result of the surgery or treatment itself. Finally, we get on to amnion. This is a very hot topic. Why is that? Well, amnion is a point of care product, so you don't have to take it from anywhere. You just take it from the fridge where it's stored and you inject it just like you would say a steroid or anything else that's off the shelf. And so clearly there's some advantage there. It's a point of care product and you don't necessarily have to invade the patient at all to get that product into the joint. You just have to inject it. The biggest question is, are there cells in amniotic products? And the bigger question now is, will the FDA approve this? Right now, all amniotic injectables for knee osteoarthritis have been pulled from the market outside of clinical trials due to the FDA 2021 memo of enforcement. They were on the market prior to June 3rd, but every company that I'm aware of has pulled them simply due to compliance concerns. And so I think we'll have a big delay over the next 2 to 5 years of trials understanding the use of amnion. And by then the technology might even be outdated. So more to come on that. Finally, what about direct visualization? And I think this is a critical area of interest, particularly in small joints, such as the foot and ankle. And the use of needle arthroscopy has really helped revolutionize my practice for a variety of reasons. But for the treatment of biologics, I think it has a real role. And essentially, you can avoid using ultrasound or fluoro. And I'll play this video, and this is in the knee, but you could extrapolate it to the ankle. But right in the office, you could use a tiny needle-based arthroscopy device after numbing the patient's skin and insufflating the area of interest, in this case, the knee joint, and injecting your local anesthetic. And finally, using this needle-based arthroscopy device to actually look into the area that you're injecting your biologic. So in this case, I was doing this procedure in the office to stage a cartilage transplant. And you'll see in a minute on the screen, you're actually looking at a picture of the picture, which is kind of cool in terms of how high def this is. But you could easily see if you're scoping the ankle joint or even a smaller toe or foot joint articulation, where you could visualize yourself injecting the adipose or injecting the bone marrow, injecting the PRP, or potentially doing endoscopy with this needle-based scope for Achilles structures, et cetera. So lots of different potential applications for using a needle-based arthroscopy device in the office or in the procedure room to visualize your biologic going into the joint. So at the end of the day, there's lots of different tools in our biologics toolbox. What do we use? Well, the jury's out. We've got to figure that out, and we need more research. And it really does depend on the joint and the issue at play. When do we use it? How do we get it there? And how do we keep it there? I think the jury's still out on those questions too. And one thing we haven't discussed, but that is critical, at least in my mind, is patient age, sex, and overall health. Is taking bone marrow from an 80-year-old diabetic the same as taking it from a 20-year-old marathon runner without diabetes? Probably not. But if we're doing the same procedure in both individuals, are we really expecting the same results? Certainly, clinical trials are needed to better understand these points. And with that, I'd be happy to take any questions. And again, thank you so much for having me.
Awesome. Thanks so much, Rachel. That was great. Does anybody have any questions?
I have a question. So I know there's literature in the knee that people who have had microfracture don't do as well with a more biologic procedure later, such as a Macy procedure. Are you against microfracture in the knee if you're planning something like that? And the same goes for the ankle. If you have sort of a cartilage only lesion, do you recommend microfracture plus say PRP or Macy or just the latter two by themselves?
Yeah, great question. I would say, at least in the knee, microfractures fallen out of favor because there are, not because it's bad, but because there are better options in general. And the durability of microfracture after 5 years has been shown time and time again to go way down relative to other procedures. I would personally never do a microfracture if you're planning on doing another cartilage surgery in the future, such as a Macy. that for sure burns bridges. Whether or not you're adding biologic at that time, it's irrelevant, at least in the knee. So if you're saying, I'm going to do this microfracture, I want it to last you a couple of years, and then I'm going to go do a MACI, in my opinion, that's the wrong answer, because there are, again, at least in the knee, there's data to show that MACI after microfracture is not as good as MACI performed without a prior microfracture. And that has really nothing to do with the biologic nature of MACI or the biologic nature of microfracture. It's due to injuring the subchondral plate from the actual microfracture. I would say now I actually don't do microfracture in my practice because there's much more advanced cartilage procedures that we do. If I ever do perform a microfracture, it's typically as the control arm of a clinical trial for one of the cartilage trials that I'm participating in. And finally, there in the shoulder, if I do a microfracture, because it's a non-weight bearing joint, I do think it's a relatively decent procedure for the shoulder. I'm always adding plus to that, whether it's bone marrow or PRP, but some sort of microfracture plus. I think microfracture in and of itself, at least in the knee joint, is falling out of favor for most high volume cartilage surgeons because of the other potential good treatment options that we know are much more durable. I would suggest that if you're going to do a microfracture, say for a Taylor OCD or something like that, I would consider adding a biologic. The literature is pretty favorable on that.
Great, thanks a lot. Great
Thank you.
talk.
Thanks.
Hey, Rachel, this is Dan. If you could just comment a little bit about who is doing these things out there. Obviously, if it's biologic augmented surgical interventions, then it's probably mostly physicians or perhaps podiatrists, but in the foot and ankle space. But I mean, 3 years ago, I remember talking to a government official about all the issues we were facing with lots of people coming in without MD backgrounds or DO backgrounds and performing stem cell injections, and how that might change your conversation with patients. I find sometimes it's much easier to have a de novo patient who has thoughtful questions, based on internet research, as opposed to someone who's been through a boiler room presentation.
Yeah, it's a great question. This remains an area of frustration, I think, for all of us. Unfortunately, I would say it's less surgeons and non-surgical physicians performing these injections, at least here in Colorado, than actual physicians. I can tell you, I got approached by industry 2 years ago to teach needle arthroscopy to a local non-surgical office so that they could perform these biologics under direct visualization, as I was suggesting. And of course, I flat out refused, because once that happens and there's an infection, who's going to take care of that, and who's going to take care of the complication, et cetera. There are many of these stem cell minute clinics where chiropractors are hiring PAs and nurse practitioners to do the injection, but then the chiropractor's billing for it. There are many clinics where it's not a physician who are performing these injections and who are promising the world to the patient. So I think this will continue to get worse and not better until the FDA really cracks down on this over the next few years. And we just have to do our due diligence. I know, in my office, when it comes to knee biologics, I typically do have either myself or my PA perform these under ultrasound guidance. And if it's in the shoulder or the hip or the ankle, I'm often sending out to one of our non-operative sports medicine colleagues who again performs these under ultrasound or fluoro in the office. And I think that, those are hands that I can trust. If I'm referring to one of our non-op colleagues who does a ton of injections, I feel confident that the injection is going to go into the right place. But yeah, this is a difficult conversation with patients. I think the most difficult one is when they come in and they say, I have money to pay, give me the stem cell. And, you have to talk them off the ledge and say, I'm not taking your money. I don't feel good about that. This is why. And the easier answer would be to say, yeah, I'll take it. I'll take your cash and let's just do the injection. So the harder conversation sometimes is the right one, of course, and that can be very difficult.
Yeah, thanks.
Yep.
Any other questions?
All right, go get them.
All right. Perfect. Well, thank you, Dr. Frank. Here's our rounding applause here. Since
Thank
for
you very
Zoom,
much.
we need a sound bite with that. But thank you. That was great.
Thank you so much. Have a great day.
Thank you.
Thank you.